In this video, I will be discussing the intersection of immigration policy and reproductive justice along the United States-Mexico border. Recent policy changes have led to the structural vulnerability of immigrants impacting their reproductive autonomy. Current immigration policies, reproductive freedom, and access to health care intersect in ways to disproportionately affect pregnant migrants in the U.S.-Mexico border region. Many factors, such as a lack of education, insurance, high cesarean birth rates, intimate partner violence, as well as other stressors, make migrant women more structurally vulnerable and likely to face structural violence. Structural violence is the discrimination and maltreatment resulting from structural inequalities that prevent people from meeting their basic needs. This is a way of documenting the negative physical effects of structures and systems. This is presented in De Leon's The Land of Open Graves, as well as in the work of Messing, Faby, and Rosen, as well as Heffernan. Understanding structural violence in the context of pregnant women at the border requires a broader lens of the border region itself. A key concept from Jason De Leon's book discusses the idea of prevention through deterrence, which is a government strategy to deliberately funnel migrants into the most strenuous areas of the desert. Prevention through deterrence is a great example of a concept discussed by Heckert, stating, "Bureaucratic violence brings attention to the ways that it is not always the law itself that causes harm, but rather the enactment of law via bureaucracy. Some laws at face value are not exclusionary. However, the enactment of policies can generate exclusion. The policy of prevention through deterrence is a killing mechanism used to disguise migrant deaths in the harmful environmental conditions without taking the blame. Clearly, for pregnant migrants, these conditions would be exponentially more difficult and put them at even greater risk." The use of detention centers is a critical aspect of structural violence towards immigrants. I say detention in quotes because this is another tactic used by the government to make the conditions sound less bad by avoiding the terms like prison or jail, when in reality their conditions are parallel to those of prisons or jails. Messi, Fabing, and Rosen explain in their work how the use of these centers is a way to control reproductive autonomy as another tool of immigration enforcement. Heffernan explains how the detention and treatment of these pregnant migrants is part of a continuum of gendered violence. The impact of structural violence in detention centers has prevented undocumented minors from accessing abortion care, which plays a role in the high rates of adolescent pregnancy. These women in detention centers are subject to dangerous practices that put both their health and the baby's health at risk, resulting in stillbirths, miscarriages, and other health issues for the mother. In particular, these conditions can be seen at the Juarez migrant camp in Mexico in this photograph. In 2019, migrants were told to wait out their asylum process in Mexico and often had no choice but to return to these camps. This camp in particular had 600 pregnant women. Then, during the pandemic, the Title 42 expulsions led to the immediate deportation of pregnant women and women with newborns who were left and told to walk back to Mexico. Now that we have seen the structural violence that is taking place at the U.S.-Mexico border, let's take a look at some factors that make women in this region more structurally vulnerable to facing this violence. The first factors that make these women structurally vulnerable are immigration-related stress and intimate partner violence during pregnancy in the border region. Solis and Hecker highlight how legal violence generates harm via processes of embodiment and entrapment. Systemic barriers are set up to limit movement for migrants, including the use of checkpoints. Checkpoints can prevent a person from leaving an abusive relationship or traveling to seek care. Psychological responses resulting from this distress can also have impacts on the baby, such as low birth weight, preterm birth, and hypertensive conditions due to maternal stress. Another key factor is prenatal care access, which is a very high priority for women on both sides of the border. Unfortunately, however, in the border region, there is a large number of mothers who are without prenatal care. 1/3 of pregnant women are put at risk of higher rates of preterm birth, low birth weight, and infant mortality due to the lack of access to prenatal care. This map shows the border region states' access to prenatal care in 2009. It is very evident that the regions closest to the border are in lighter color, which means they are lacking prenatal care. Due to the lack of access to prenatal care, there are very concerning medical impacts on both the mother and the baby. There were found to be higher rates of preterm birth, low birth weight, infant mortality, and neural tube defects. It was found that Hispanic women have greater maternal risk factors that can be positively impacted by early inadequate prenatal care. Morris wrote that in border regions, Latinas with compounded disadvantage, such as low education or no private health insurance, have a higher cesarean rate than other women. Another factor was high rates of adolescent pregnancy. One example was the city of Nogales, which I photographed in the photo on the screen. As you can see, this is one city split by a wall, which on one side is Nogales, Arizona, and on the other side is Nogales, Sonora, Mexico. The state of Sonora has the highest rates of adolescent births in Mexico, with 1 in 5 births being an adolescent mother. Nogales, Mexico accounts for 10% of adolescent births in Sonora, despite only being 7% of the population. Factors that increase the risk of adolescent pregnancy, based on the study of Elizabeth Reed, included housing instability, which created stress and uncertainties in their lives. The second factor was food insecurity, which was a result of a lack of financial resources and turning to their social network to access food. The third was disproportionate allocation of limited economic resources to male siblings, discussing that due to the lack of money, the parents used what little resources they had to provide for the males over the females. The next factor was reduced expectations for future education and career opportunities, which also stemmed from economic constraints. Finally, the economic reliance on male partners with implications for male partner control over pregnancy. This was due to their need for male partners to provide their basic needs as a financial reliance. This caused emotional connections and security with the male figure, making them believe they could also provide for their children. So, after learning about what is taking place at the border of our country, you may be asking yourself what is being done to prevent this issue. One program is the Healthy Start Initiative, which is run by the U.S. Department of Health and Human Services to eliminate disparities in perinatal health in communities with poor birth outcomes. They provide prenatal case management for vulnerable pregnant families to improve access and quality of services. They do this using the community health worker model for home visiting and have adopted programs to empower women with life skills and mental health resilience.